So I hope everyone's keeping safe and has been relatively all right with everything that's going on. If anyone wants to talk about anything, then as usual, feel free to message me on Facebook if something's been going on or you have any questions about anything, or I'll stick around at the end as well. So we've got a couple of cases today. We will start with this one. So you've got Hassan Mehdi. You're the F2 and GP in this situation. You've got this 3-year-old boy, and he's been brought in by his mum. She's also brought her 8-year-old son as well, because it's a school holiday. No one else to look after him. And she's a bit worried about him. It's a bit of a vague thing. She says he's a bit different to what her other son was like at his age. You ask sort of, what do you mean by different? And she says, well, he doesn't really seem really interested in playing with toys or interacting with other people. And when he's at nursery, he seems quite happy just sitting by himself in a corner. If kids just try to like pull him along to play with them, he can get quite upset, screams. And apart from 2 of these ladies at the nursery, his brother and his mum, he seems quite uncomfortable around other people. Even in the consultation room, he's sat in his mum's lap and he's not really looking at you. He's just sort of staring off into space, occasionally looking at his mum when she mentions his name. What sort of stuff would you like to ask? That's sort of what the mum's started off with. Yeah, so how does he play? He just doesn't really. He's not interested in toys. He's literally not interested in toys at all. Like, his mum's gotten him stuff and his brother's hand-me-downs toys, and he just doesn't really care about them. Language, good. So his language seems to be fine. He talks. It's just his mum and his brother seems to talk to them fine. But other than that, and the 2 nursery workers, he's pretty quiet. But that's really, really good. In terms of how many words he can speak, he's sort of going at what you'd expect for his age, really. So he can understand things like negatives and adjectives. So his speech seems fine. Okay, so that's really good. Language and toys. His mum's not entirely sure when she first noticed that he was quite different. She says that even from a young age, he's not been sort of particularly engaging with people apart from her and his brother. It's just she thought maybe it would change once he's exposed to more kids, but it hasn't really once he's been at nursery. He doesn't have, so at home, he's fine. He's quite stubborn. He likes to stick to a particular routine of things. He doesn't like it if it's sort of disrupted. So he has his own spoon. He refuses to eat with any other spoon that isn't his. He is interested. So James said, does he interact with those he's more familiar with? Yeah, he does. He's sort of engaged with them, but not particularly interested in what they do. He won't sort of go around and copy his brother or follow his brother around. But if they try to interact with him, he'll interact with them. Repetitive behaviors, his mum hasn't noticed any repetitive behaviors, no tics or sort of self-stimulatory behaviors. And she's asked a really good one, which is any regression in milestones already achieved, and she hasn't noticed that. He hasn't gone backwards. He is quite sensitive to loud noises, so Claudia's asked. So if there's sort of a siren going by, he gets quite distressed. He can cry because of it, and he doesn't like being in crowds. Really good. And Tisha said, did mum have all her antenatal scans? Anything come up? Pregnancy was uncomplicated. Everything was fine there. All scans were fine. So Valeria's asked, does he like routines? Really likes routines. Like we said, he has his spoon. He wants to be in bed by a certain time. He does not like any deviations. Motor skills, yep, he's running. He's got a tricycle that he'll go on. That's one of the few things that he actually seems to like. But his motor skills are fine. He walks fine. He walked appropriately, so he started walking at about 15 months unaided. He was crawling at 8 months. He can run. He's okay with stairs for his age, so he goes up 1 foot at a time and goes down. He has to get both feet on the step to go down. No genetic conditions in the family. His dad had ADHD, but no genetic conditions that they know of. You're doing really good, guys. Well done. This is really, really thorough. So far what we got is good. Is an activity that he's extremely invested in. So nothing that his mum can think about in particular. Sort of, there's not anything that sort of particularly engages him. He just seems quite happy sitting around, sort of, she thinks sort of in his own head, daydreaming. She doesn't really know what he's doing when he's just sat there. But there's not any particular thing that he seems focused on. He is in nursery and he likes to be on his own in nursery. He doesn't seem particularly interested in spending time with other children, parallel play, anything like that. And there's only 2 staff who he's kind of comfortable around. Otherwise, he's not very, he's not particularly happy to be around or interact with other people. And he can get quite stressed, screaming, crying. Fine motor, so yep, he can draw if he's asked to. He's not particularly interested in doing it, but he can do it. He's feeding himself with a spoon and a fork, so it seems like fine motor is completely fine. No social worker. They've not had to have a social worker. That's an excellent question as well. So no input from social care. They're not a family under what's it called? Family of concern or anything like that. Perfect. All immunizations are up to date. Nothing postnatal. So he was born, it was an instrumental delivery, but no problems there. He didn't have to go to NICU. Yes, perfect. Really good question. No concerns about vision or hearing. He had his hearing checked at birth. It was fine. And there's no concerns about his vision. Really, really good. No family history of autism spectrum disorder. It's just the dad had ADHD. No, the parents weren't related. Excellent, really good question as well. So what we've got so far, what you've listed so far, which is excellent, is in terms of gross and fine motor, he seems fine. His speech and language as well seems fine. It's just the social side of things. He's not really interested in toys, other kids. He doesn't really imitate. He doesn't follow his brother around or his mum. He'll cling to his mum outside because she's quite comfortable, or he'll stay very close to his brother, and he does get along with them, but he doesn't really seem interested in much. You ask, his mum said that his first smile was at 12 weeks. Anyone know when the sort of upper cutoff for social smile is, where you're starting to think, okay, that's a bit late, the child should have smiled by now? That's a bit of, yeah, so 8 weeks is concern, 10 weeks, they should have smiled, they should be smiling around 6 to 8. If they haven't smiled by 8, it's a bit, and then James is right, at 10 weeks, if they haven't smiled, then it's, okay, we might want to get that checked out, because most likely at that point, it might be a problem with vision, but it's also an early indicator of some form of social difficulty. However, in order to do that, the patient does have to present, and in the case of this mum, she's only brought Hassan over now. This is the first time she's actually brought him complaining of concerns, which is why it hasn't actually been referred yet. Okay, perfect. So in terms of other bits of information that you sort of picked up, he's got no past medical history. Physically, he's a well child, hasn't really needed to hasn't ever been to hospital actually. His dad had ADHD, like we said. He's not really on any medicines. During the week, he's at nursery. It's just his mum and his brother at home. His dad died in a car accident when he was one. His mum doesn't smoke, and she's quite under pressure at work and a bit stressed out because she's having to have the kids at nursery and the older sibling in sort of an after school club because she works quite late. But she feels safe. There aren't any safeguarding concerns there. And like we said, whilst you're looking, he seems quite disinterested and blank. He doesn't look at you. It seems, and when you say, if I can examine him, and you reach for him, and really sort of moves away from you and starts, vocalizing, no, doesn't want to be anywhere near you. So what are we thinking at this point? Yeah, perfect. Referral for autism assessment, which highlights an important thing. You can't diagnose autism in primary care. A lot of the stuff with children, especially developmental stuff, requires referral to at least a community pediatrician. You can't really diagnose developmental problems definitively as a GP. You need a specialist. Perfect. Referral for autism assessment. So one of the things that I did want to highlight in this is that if developmental issues come up in exams, they will be fairly clear-cut. They won't try and make it confusing, like, oh, is this autism, is this ADHD? They will be quite stereotypical. And usually with developmental conditions, it's most likely going to be something like cerebral palsy if it's motor. The reason why AC's question of any regression is really important, because they will put that in if they want you to think of something like Duchenne's muscular dystrophy in a boy who's regressing, and autism and ADHD are the main behavioral ones that they will ask. So they will usually make it quite clear cut. Oh, also, I just forgot to mention an important question is asking about centiles. So if there's been any change in growth and weight centiles during the past 3 years, has he gone up? Has he gone down? Is he roughly the same? Okay, so there's not an awful lot that you need to know about autism or a lot of the behavioral stuff for children as a medical student, other than being able to recognize them and recognizing them enough to know I should refer to somebody who is an expert on this. Everyone who said something in the chat has essentially picked up on all of these. You've asked about stereotypical behaviors. You've asked about inflexible, sort of, are they fixed on a particular thing? Are they rather inflexible? Do they have social difficulties? Do they have language difficulties? Because language difficulties are quite common. It's obviously important to remember that autism's a spectrum, because you can have people on the milder end who have no language difficulties, and it's just the social side, and that's what is, or more commonly was, referred to as Asperger's syndrome, which can get quite severe on the social side. But the important thing is when you talk about somebody with Asperger's, language-wise and cognitively, they are fine. It's the social stuff which is the problem, all the way to the really severe autism spectrum, which is a child who's non-vocal and has severe intellectual disability. Remember, it's the most common behavioral comorbidity with Down syndrome, so autism spectrum and Down syndrome, and it's got strong comorbidity with ADHD, something in the 35%, and also epilepsy, which is around 20%. So they do have, because it's neurodevelopmental, they do have significant comorbidities. Generally, as is a recurring trend with most of the PEDS behavioral stuff, you don't use medications. If you see medications, it's for comorbidities like agitation and so on. Really, the most important thing is getting involved early, specialist educational intervention, behavioral intervention, and also family counselling, because it can be quite difficult. But you're not expected to know an awful lot about autism. Same thing with ADHD, for example, which we'll touch on in a second. Right. Developmental milestones are annoyingly important. The annoying reason is, as an F1, you're never really going to be using them. And the other annoying thing is they do come up in exams. It was an OSCE station 2 weeks ago for me. So they do come up. They will probably come up in your OSCE. If they don't come up in your OSCE, well, yeah, they'll come up. They're almost certainly going to come up in your OSCE this year. So it's worth knowing them. The problem is there's so many of them that it's difficult, which is why memory aids are fantastic. I've put a couple of the ones I found most useful. I won't go through them because I don't think that's the most productive use of your time. But the link I put there, I literally watched the night before my OSCE, and it was a lifesaver. It completely saved my life essentially for that station. You have other things like the photos on the right. So for stuff like fine motor, which is what what James was talking about. So things like, can they draw circles? What shapes can they draw? Things like that. Often you probably won't be asking a parent, can they draw a circle? Because they might not know. This is something which you might do if you have the child there with you. And for us, at least, it was a video, pardon me, someone asking the child, draw this, draw that, and seeing what they could do. But yeah, this is one of those things where memory aids are incredibly invaluable. Another thing to point out is the primitive reflexes. So things like the Moro reflex, 4 letters, disappears at 4 months. The rooting reflex, the root of rooting is root, 4 letters, that goes at 4 months. The Palmer reflex goes at 6 months, which is a shame because it's adorable. And the Babinski reflex, which is normal in children up until 12 months, because they haven't myelinated their corticospinal tract up until that point. So that's when they're supposed to go. If they're still around, if they've still got the Moro reflex, 7 months, that's weird. Some kids keep it up until 6 months. But yeah, that's a useful thing for that. But all I will say for developmental milestones is use as many memory aids as you can. Even if you make up your own silly ones, they're useful. And another thing which I found incredibly useful is this slide. This one is identification of red flags early on. So I didn't memorize it, but I just used it to give myself a good idea, especially the bit at the end, which is red flags at any age. A really important thing in peds, actually, which I don't think is brought up enough in medical school, is that if the parent is worried, even in the physical side of things, parental concern is at least an amber flag on the traffic light system. So even if the kid seems fine, but the parent's like something isn't right, that's a cause for concern, usually. Because sure, you get anxious parents, but also the parent knows the child better than any of us do. So yeah, developmental milestones, all I will say is, yeah, use as many as many memory aids as you can. Whilst you're sort of taking the history and so on from Hassan's mum, you notice that his brother's walking around the consultation room, sort of poking at things, looking at the urine dip bottle, opening it up, and his mum tells him, stop it, sit down. And he starts screaming at her. He's repeatedly saying, no, no, no. He's getting quite flustered. His face is going red. And his mum mentions, actually, I'm really sorry. I'm just having a lot of trouble with him. Same at school. So there are 2 conditions which essentially crop up in SBAs around difficult behavior or challenging behavior in a child who doesn't have a learning difficulty. What are our differentials here? Yay, perfect. Okay, so ADHD has been mentioned, which is fantastic. And then oppositional defiant and conduct disorder. Excellent. Right. So we've got ADHD, which is a neurodevelopmental disorder, and we've got the oppositional defiant conduct disorder side of things. What sort of questions could you? You could obviously right now you're going to say if you want book another appointment for the older brother, but let's say if you're in that situation and you're thinking it could be ADHD or it could be ODD/conduct disorder. Separate on the next slide. What sort of questions could you ask that might help with that? They are not the same thing, and we'll talk about that on the next slide. I've just separated them here because ADHD is neurodevelopmental, whereas conduct disorder and oppositional defiant disorder are behavioral rather than neurodevelopmental. So there's less, that doesn't appear to be as strong a biological thing. So pervasive is a good question, but the thing is all of those tend to be pervasive. Yes, attention, good. So that's one of the big things. Can they focus on stuff? Excellent. So as he said, for conduct, and those are really important ones. Do they destroy other people's property? Do they lie? Do they hurt other people? That's very specific for conduct disorder. You don't see that in other conditions. Said, his behavior is directed at authority figures only, like teachers or parents, which is good, because in something like ADHD, it's essentially everyone will be affected. Siblings, parents, teachers, other school children. The behaviors aren't particularly specific. Whereas in something like oppositional defiant disorder, it's usually figures of authority. Figures of authority is oppositional defiant disorder. There's defiance to people in authority. And then James has talked about hyperactivity. So essentially ADHD is nice because it tells you what the two main domains are, which is their attention and their activity. You can have hyperactivity dominant ADHD and attention deficit dominant ADHD, but most commonly there are features of both. A child with conduct disorder, or ODD, can most likely focus on stuff. They've got the ability to maintain their attention, and they can usually sit still, stuff like that, and aren't impulsive. Do bear in mind, of course, that people get comorbidities, and you can have a patient with ADHD and ODD, or with ADHD and conduct disorder. You don't really get patients with you don't get patients with ODD and conduct disorder, because they're basically they are separate entities but on the same sort of domain of conduct disorder is a way worse version of ODD. So usually if someone's got conduct disorder, they've got the ODD traits and other worse things. So good. So ADHD is the one that you want to screen for, but really all of this warrants a referral. Essentially, your job as a GP is spot these things and refer to CAMHS or relevant or community pediatrician if you're worried more about neurodevelopmental stuff. So CAMHS, so child and adolescent mental health stuff, has been requested a few times in feedback. So here is your SBA stuff in a nutshell for CAMHS, because it doesn't come up a lot, and they're not often going to chuck a psych station and an OSCE on CAMHS. If it is, it's usually going to be explaining to a parent something, explaining autism to a parent, explaining ADHD to a parent, rather than prescribing or something like that. That latter point is important because really there aren't a lot of drugs that are used in CAMHS, and they're only used for the most severe cases. SBA things to bear in mind: fluoxetine is the only antidepressant that's licensed for use in children. You might see other ones, but those are off license. Sertraline, for example, or citalopram, and those are in patients who haven't responded to fluoxetine. You won't see, I'd be very surprised if any of you have or will see a patient on an antipsychotic, isn't a child on an antipsychotic. Though if you do see them, it's usually a very behaviorally distressed child, so very agitated and disruptive, who's being given the antipsychotic as essentially a sedative, really, a long-term sedative, or even rarer, a child with actual psychosis, which is really rare and also really scary. ADHD, usually you will be asked more about the pharmacological side in SBAs, because the conservative or non-pharmacological side, as with most of the stuff here, is essentially behavioral interventions and therapy and family therapy. Same with eating disorders, for example. The important things to know in terms of SBAs, and this is something which PassMed does quite well: first line's methylphenidate, aka Ritalin. If they're on it, you need to check their growth every 6 months because it can stunt growth. And a UCL SBA favorite is which of the following is true about ADHD? And in that question, the true bit is that during school holidays, especially if the person's ADHD is at its worst when they're in school, you can stop or reduce the dose of methylphenidate to minimize the effect of it on their growth. So a drug holiday, basically, to coincide with their school holidays, like their summer holiday or half term. So that's come up a few times in the past. Second line is dexamphetamine, but we don't often get asked about second lines in psychiatry, apart from, well, clozapine is a third line, so you don't really need to worry about that too much. So ADHD, if it's an SBA, they'll most likely ask you about medication. If it's the OSCE, they might ask you to explain it to a patient, so to a parent. Finally, we've got ODD versus conduct, which is the other big thing in CAMHS in SBAs. This is rather a straightforward split. If they are violent, it's conduct disorder. ODD does not tend to be. If they are doing things which are basically criminal, it's conduct disorders. That's the stuff the AC mentioned. So deceit, stealing, damaging other people's property. The important thing with conduct disorder as well, which can come up in SBA, is it's linked with getting antisocial personality disorder later, because they're basically the same symptoms. It's just important to remember that there's this arbitrary cutoff of you can't diagnose a personality disorder before the age of 18 because a person's personality is still developing. But usually what will happen is a patient's diagnosed with conduct disorder and they turn 18, you turn it to antisocial personality disorder, which, remember, is the closest thing to an actual diagnosis of psychopathy in the ICD or the DSM. So that's so to summarize, Floxetine, only licensed one in terms of antidepressants. ADHD, methylphenidate's first line. Thing to check is growth every 6 months, so weight and height. Can give them a drug holiday if they're pretty good outside of school. And whilst ODD they are argumentative and they are angry and they can be verbally aggressive, it doesn't cross the line to physical aggression and actually hurting other people, being violent to animals, things like that. Once it's crossed that line, it's conduct disorder, and that's got a much worse prognosis because it goes into antisocial personality disorder, which is very difficult to treat, and they usually end up in, well, the forensic system, so committing crimes, getting arrested. So that's essentially the SBA nutshell for CAMHS, really. And pretty much, yeah, if it's an SBA, that's what you need to know. If it's an OSCE, I'm willing to wager good money that if it's a CAMHS OSCE station, it's explain autism or ADHD to a parent, and which will come more under PEDS even. Okay, if anybody's got any questions about the CAMHS side of things, or anything they want to ask about, drop that in. Next one, so this is case 2. So in this situation, we're now the medical F1, and you're doing ward cover, and it's the night. You've got Hendrik Mathers, who's a 77-year-old man, and he's been admitted and is being currently investigated for confusion. So your the med reg has gone, chase up his results, start the appropriate management. Before the results have come through, so you're waiting for bloods and so on, as an F1, so this is less of an exam thing and more of a real life thing, what are some important things? So I've got 3 things in mind. You might think of stuff which I haven't thought of, which is excellent, but what sort of things should we really be doing as the F1? Excellent. Yes, that's one of the 3 things I was thinking of. Thinking of is ceiling of care. So very good. So AMTS, a 4AT screen. So that's an important thing, but that's most likely been done on admission, or should have been done on admission. Whoever was clerking should have done the 4AT or some form of delirium screen. Excellent. So go through those. So ceiling of care is a really, really important one. If it hasn't already been put in place by the admitting doctor, who has said the ceiling of this patient's care is ward-based, the ceiling of this patient's care is ITU, this patient is for full escalation of care, then you should really be thinking about it, maybe assessing it yourself, and most probably running it by your reg and saying, hey, is this guy for just ward-based escalation? What happens when he gets more ill? Are we going to send him to ITU or not? DOLS, so if that's necessary, so DOLS is always something that you can consider, but the important thing with DOLS is it's only really warranted if you've got cause for thinking that you might need to deprive somebody's liberty. So since we haven't really mentioned that he's agitated, trying to leave, trying to climb out, you don't need to think about DOLS too hard at the moment, but it's always an important thing to think about. Delirium chart checklist, yes, good. So all the conservative measures for delirium, so trying to make him as comfortable as possible, also making sure the nurses are doing a delirium chart, excellent. Family, fantastic, yes. So notifying the family if they don't already know. So to find out really important information, is there a power of attorney? Is there an advanced decision? Stuff like that, excellent, good. There's something linked to the ceiling of care, so it goes hand in hand with ceiling of care. Whenever you're admitting a patient who's quite elderly or frail, so do not attempt resuscitation. That needs to be decided. Whilst that's obviously not an F1's job to put in place, you are probably going to want to assess that, speak with your reg. If your reg says, don't think he's for resuscitation, then actually it often is the F1 who has that discussion. And I've seen F1s go and have the do not attempt resuscitation discussion with the patient. However, the patient is confused. So you're probably going to be having it with the relative, like you has said. How come that's different to ceiling of care? So how to explain it? You might, I don't exactly know how to explain it, but they are, every hospital I've been in they are listed separately. Yeah, so like full ceiling of care is like escalation to ICU, whereas you might not be escalating somebody to ICU, but you might still be doing CPR on them. So a do not attempt resuscitation order doesn't automatically mean that their ceiling of care is not ICU. It just means you're not going to do CPR on them. Yes, which is already, yeah. So you may be in a situation where the patient is for antibiotics, for example, but not for CPR. Yeah. Thank you, Hissy and James, for helping me out there. Right. So, yep. So do not attempt resuscitation status. And also what you might find is, so in the delirium checklist, that is a good question. So usually that's more on the nursing side, but it's essentially it's not quite neuro-obs, but it's documenting how the patient is. So stuff like GCS, how aware they are they sleeping, are they not? And it's sort of done on an hourly basis. I will try and get a copy of one and post a link to it in the thing, but it's usually something where you will ask the nurses to do, and it's a sort of like observations thing. There's loads of ICU ones, but yeah, I'll find one, I'll put it in the chat. So you've done all that. Another thing which is important as an F1, especially when you're doing ward cover, is you might be the person who's prescribing the regular meds, especially if there isn't an F1 on take who might be doing that. What is an important thing to remember when you are prescribing when you are writing out the drug chart for a new patient, which will save you from being bleeped in the future? VTE, good. Do VTE prophylaxis. What's another one that F1s get bleeped about a lot? It's like, crap, I could have fluids. What might a patient end up complaining of in the middle of the night? Allergies are important, laxatives. I'm sure if they're indicated. Yeah, so everyone's actually thought of lots of really good stuff. The one that I was thinking of was analgesia. So because everything has to be prescribed, if a patient says, can I have some paracetamol, it has to be prescribed. So something that is fairly common practice is, if you're admitting a patient, put paracetamol on their PRNs. That way, if they get a headache because it's too loud on the ward or whatever reason, you don't have to get bleeped at 2 a.m. to come over and prescribe paracetamol, especially for a hospital like the Free where everything is on paper, so you literally have to go to the ward and prescribe the paracetamol. So analgesia is what I was thinking about. Everything else, fair game. You definitely need to do allergies, yes. Fluids, if they're appropriate, yeah. I mean, if the patient can drink and they're hydrated, then maybe not. VTE, yes, always really appropriate. Laxatives, if you need them. Sedation for haloperidol and lorazepam in an agitated patient. Yep, I would definitely do that. In a patient who's not, then it's probably not necessary. Paracetamol is definitely the one I have in mind because you hear people talk about it, and also I've seen it happen way too many times. Like I'm thinking at least 10 times have I been on a night shift, just chilling with the F1, and then they get bleeped to go prescribe paracetamol, and it's really sad because they're already swamped by bleeps, and now it's one more thing to do. Oxygen, just in case. Usually, I haven't seen that done. People prescribing oxygen. Yeah. The reason for that, I think, is if a patient starts needing oxygen, you should know about it. If a patient's got a headache, like a mild headache, not really the most worrying thing. If the patient is saturating and now needs oxygen, then you kind of want to know about it. That's very different to a patient who's come in with something like an infective exacerbation of COPD, where you're obviously going to prescribe oxygen. But any patient being admitted, if there's no reason for them to have oxygen, don't prescribe it, because you kind of, if they start desaturating, you kind of want to know about it. Right. So you've thought of way more things than I have. I was thinking DNAR, sealing of care, and writing out the regular prescriptions. Okay, so moving on, bloods are back. FBC's fine. He's got an AKI, not surprising. Practically everyone does when they're admitted. And his calcium's 3.1, and his ALP is 412. Straightforward first question. What are you going to start? As the F1, this is the thing that you can actually do, because I don't expect any of us in a couple of years to be writing down IV pamidronate without actually calling our reg. Excellent. Fluids. Has anyone put the aggressive word? Okay, no one's put aggressive. They always use the word aggressive IV fluids, and I kind of want to ask, what do you mean by what is meant by the word aggressive? Aggressive, and usually it's stuff like you'll see them getting a liter in an hour is the idea of aggressive, and then you'll start them on eight hourly bags. If you're giving them fluids, a catheter is a good idea. Yep, you want to measure fluid balance. ECG, everyone's, an ECG is definitely good. I'd ask for treatment, but yeah, that's something you'll definitely be doing alongside it. What do you need to do before you start the IV fluids? What is important before anyone gets fluids? Really simple thing, but pretty important. Takes about 2 minutes. Blood pressure is part of this, so yeah, OBS, check for heart weight. Yeah, fluid assessment, which will involve checking for heart failure and stuff like that. Weight is also really important. Weight's a really important one because not a lot of people. It's a big problem in a lot of hospitals. If you've been around Barnet, there's signs everywhere saying weigh your patient, because it's obviously important for stuff like gent, but also for fluids and so on. But fluid assessment is the stuff that I think about. Oh yeah, and consent if you can get it, otherwise best interests. But yeah, so do a fluid assessment. You don't want to be giving a liter in an hour to a person with heart failure. So fluid assessment, because remember, it's your name on that drug chart. You're the one prescribing the fluids. So do a fluid status assessment. Now, we've got somebody who is incredibly hypercalcemic. What single add-on blood test will help us figure out what the etiology is? Let's see, PTH, yes. So we want our parathyroid hormone. Good, because what are the two most common causes of hypercalcemia, especially in an elderly patient? Yay, primary hyperparathyroidism or malignancy. Perfect. So malignancy, including myeloma or hyperparathyroidism. Yay, fantastic. AKIs, not as common. Often somebody with hypercalcemia will go into an AKI because they will end up really dehydrated. But perhaps, I do not know about that though. So you add on the PTH and it comes back and the PTH is really low. It's really, really low. And you let your reg know. They ask you to book some imaging. What imaging do you think they might be asking you to do? And a patient with low PTH and hypercalcemia, given the most likely differential. Yes, perfect. Got it in one. So CT chest, abdomen, pelvis, because this is quite likely a malignancy of unknown origin. Perfect. So you book that, and unfortunately, it comes back and you've got sort of abnormal iliac lymph nodes and sclerotic bony lesions throughout the body, ribs, vertebra, ilium. So what's the most likely diagnosis in this patient? Yeah, perfect. Prostate cancer. If you see sclerotic bony lesions in an SBA, it is basically prostate cancer in SBA. Obviously, there are other things which can cause it, but in SBA, they're going for prostate cancer. So first of all, in terms of imaging, what's the best imaging for prostate cancer? Yeah, perfect. Multiparametric MRI. That's the buzz phrase that you're looking for, the phrase multiparametric MRI. And then what investigation is the gold standard for it? So to actually diagnose. Yeah, perfect. So transrectal ultrasound guided biopsy. That's the important bit. They used to do it transperineally, but now it's transrectal, um, just because, well, A, it's less painful and uncomfortable. Okay, so let's say they do the biopsy and unfortunately it comes back as prostate cancer and it is metastatic prostate cancer. The patient's confused, so you find the next of kin, who's the daughter. And she was told in person yesterday. She came in person, and one the consultant spoke with her. But today she's called back. So this is a few days after he's come in, and stuff has progressed. And she wants to talk to one of the doctors, and you're the one talking to her. And she's quite upset because she's wondering why her dad's cancer got picked up so late, to the point where it's now metastatic. She remembers her uncle, so her dad's brother, had prostate cancer, and it was picked up quite early because of a blood test. And you ask her a bit more and you figure out she's talking about the PSA, and she wants to know why this wasn't done as her father. Now, remember, her dad was asymptomatic. He didn't have any symptoms of prostate cancer leading up to this, as far as the daughter knows. So she's asking why wasn't the PSA done as a routine thing? What will you tell her? Perfect. Yep. So the first most important thing is to be human. She's upset. Acknowledge that. And there is no screening program for prostate cancer. And why is it that we don't use the PSA for? Why is it that we don't use the PSA for screening for prostate cancer? Good. It's got a high rate of false positives. The PSA's got a really high rate of false positives. That's all right. Its positive predictive value sits around like 25-30%. So for every 10 people with high PSA, 3 of them have cancer, which means 7 of them who are getting unnecessary investigations. If it's a biopsy, it's an uncomfortable investigation. So let's just spend a little bit of time talking about counselling for a PSA. So who can you how do I word this? Who can you order a PSA for? What's nice? Who does nice say? Yeah, it's this is all right. You can order a PSA for this person. So yeah, you can do it at GP. Almost, yeah, perfect. Any man over 50 who requests it, as long as you've given them informed consent, you can do it. Or if they've got symptoms, which you've nailed. So any man, uh, if they're asymptomatic but over 50 and they want it, you can offer it. If they're any age and they've got something going on, like a weird digital rectal exam, like Sarah said, or they've got hematuria or anything that could really make you suspicious of advanced prostate cancer, how many times can they request it? There really is no limit, to be honest. I think eventually what probably happens if they keep on coming back and requesting it, you're going to have to sit down and explain to them, look, this isn't something that's going to change an awful lot. But what might end up happening is you just end up with a guy who you're doing their PSA every year, because as long as they have capacity and they understand the benefits and drawbacks of it, there's really no limit to how much they could request it. So it sort of becomes a more bureaucratic thing, and appeasing the patient, a balance between resources and patient appeasement. So does the patient, is the patient coming every month asking for it, maybe negotiating and saying, okay, we can do it annually with the rest of your bloods, but we're not doing it every month. But yeah, Perfect. So if they've got unexplained unexplained symptoms, like like hematuria or a lower urinary tract symptoms with normal dipstick, so it's not a UTI, or you're suspicious about prostate cancer, you shouldn't be giving it to asymptomatic men. Is the gist of it, unless they're over 50 and they are requesting it. In terms of benefits, so obviously the benefit of the PSA is you might detect a cancer early and treat it. Limitations, we've already said there's a significant false positive rate, which is unnecessary investigation, which can be quite uncomfortable. What's another problem, which is kind of specific to prostate cancer? Let's say you do the PSA and it comes back high, and you actually find out that this person does have prostate cancer. What's an issue that might arise out of that? Yeah, so you're getting towards what I was thinking. Yeah, so then the issues with the treatment. So exactly, yeah, you've all nailed it. Prostate cancer can often be, especially in the less severe cases, managed with just watchful waiting, and a person's not. Yeah, so Claudia's hit the nail on the head, which is, if it's really low grade, you're probably going to die of something else, and it wouldn't have affected your life. But now that we've found it, and you want it treated, you then get all the side effects of treatment, like James has mentioned, things like erectile dysfunction, and your quality of life actually ends up worse, which is something that people don't often think about when they're requesting a PSA. The other thing is also it's got a 15% false negative rate, so it could be falsely reassuring sometimes. Yeah, exactly. Yeah, literally just what I said. Well done, nice. So on the flip side, it can be falsely reassuring, because really poorly differentiated cancers can have a normal PSA. So excellent, right? And in terms of the practical stuff, so this comes up on PassMed a lot. When should you not take a PSA, or like how long should you wait after certain things before you take a PSA? So it's 48 after it's no DRE was oh no DRE was hang on. Actually, DRE, can't remember the DRE one. But yeah, so 48 hours for ejaculation or vigorous exercise. 4 weeks after an infection is correct. And then what was it? Okay, 1 week. Okay, 1 week for DRE. Okay, I'll trust that. Yeah, so 48 hours for ejaculation or vigorous exercise, 6 weeks for biopsy, up to 4 weeks for a prostate infection, and it can stay elevated for ages after prostatitis, like 6 months or something. And it's a week for a DRE. Yeah, that makes sense. Cool. One thing I just forgot to say, whilst you're on the phone to the daughter, what else could you ask about that would be useful? Kind of already got mentioned actually by Issy like 15 minutes ago, but just always really useful when you're talking to next of kin for the first time. Family history, yeah, could be, but in terms of something that's useful for future management decisions. Yeah, perfect. It was asking about expression of previous wishes. Fantastic, good. Right, so that's all the stuff that we just talked about. NICE says that if it's a patient who's between 50 and 69 and their PSA is over 3, then you do a 2-week wait referral. If they are 70 and above and it's over 4, then you do a 2-week wait referral. And even if the PSA is actually normal in a 50 to 69-year-old, but you're still suspicious, like they've got a weird rectal exam, then you're still going to refer them. But I wouldn't really worry about those figures. But as you can see, the PSA is a bit of a tenuous and is a controversial biomarker for prostate cancer. So, last bit we're going to talk about, do some prescribing. So you're on day 5 of his admission. His calcium's coming back down. He's no longer confused. He knows about his diagnosis, and the Macmillan nurses have seen him, providing him and his family with support. The team has agreed, if they don't meet PSA levels for referral, reassure, basically. Yeah. If they don't have symptoms, they don't meet it, then reassure. Let's say their DRE is fine, their PSA is 2, it's a 77-year-old man, he's asymptomatic, then it's okay, reassure. Because if you referred that to urology, they'd be like, why have you done this? But yeah, so prostate cancer team goes, he's for palliative care because he's got disseminated mets. He's currently on analgesia, but today he's become quite nauseated. He's vomited twice, and the consultant wants you, if it's a smooth one, to be fair, you might not even refer, or you'd start. GPs often just manage BPH themselves. If it's a smooth enlarged prostate, you might not even actually refer, unless the PSA is really high, and then you go, maybe I should 2-week wait you just in case, because obviously BPH is a risk factor for prostate cancer. But if it's a large, smooth prostate and the PSA is 3.9 or something, usually the GP will handle that themselves. What NICE specifically says is clinical judgment, which is a bit of a cop-out, but not the wording NICE uses is in other patients outside of those last 3 bullet points. Use clinical judgment is what NICE says. So he's vomiting, and the consultant says adjust his prescription. At the moment, he's on Oromorph 15 milligrams twice a day, modified release, with the PRN of 5 milligrams, which he's using 4 times a day. He's on oral paracetamol as well, which is 1 gram. His GFR is 32, and he weighs 72 kilos because we're a good medical team and we've weighed him. Just one quick question. What's his drug chart missing at the moment? It's missing 2 things. Yeah, perfect. It's missing an antiemetic and it's missing a laxative. Fantastic, great. So if they're on opiate, antiemetic and laxative. Okay, so to adjust, if people want to take a minute to rewrite his prescription. You don't need to do it formally. I didn't want you guys to bring drug charts or whatever, but just take a minute to whip out the BNF and rest his drug chart as you see fit, basically, and we'll talk about. So first things first, in terms of the actual analgesia, what have people gone for? So drug and route, if anybody wants to volunteer. Yeah, I am happy with oxycodone. I myself would have gone for subcut just because IV's a bit. Yeah, I think the anaesthetist wouldn't be too happy about that. And then cyclizine. Yeah, uh, you could do IM. Okay, so let's talk about it. The important thing, I think one of the important things here is that there isn't a fixed right answer. So this is what I've gone for. And then we'll run through, as we're talking about that, we'll run through the questions. So cyclizine as the antiemetic seems reasonable. The least disruptive method of administration is subcut. IM hurts more than subcut. IV, especially for opioid analgesia, is also on wards is generally not a happy idea. They don't like the idea of IV opioids on wards unless it's got some form of specialist input, like the pain team. So subcut, if a patient can't take oral drugs, usually subcut's the preferred route. Cyclizine, you can give 50 milligrams up to 3 times a day, so you can give that subcut. Metoclopramide is another option, for example. If you want to give IM meds, you could. It's just like there's no contraindication to it. It's just subcut is kinder to a patient. In terms of the actual dose of the drug, so you could use morphine. The problem is because of his renal impairment, you'd have to be quite careful and you'd have to reduce the dose. So he's on a total of 50 milligrams of morphine daily if you calculate his breakthrough, which means the correct dose if you were using morphine is 25 milligrams. But because of his impaired renal function, you're probably going to want to convert that to oxycodone. And oxycodone is, or compared to oral morphine, it's 1.5 to 2 times as potent as oral morphine. But the subcut version is 3 times. So we're doing 25 divided by 3, which gives us 13.333 recurring. Now, some people might round that up, like I did. Some people might round that down, like James did. Doesn't really matter. If they were going to do an SBA, they would not do. They wouldn't make it as they wouldn't have 2 options, one which is round up, one which is round down, because usually that's dependent on the doctor prescribing and advice that you're given. Also, it's dependent on the actual available formulation. Does it come in 15 milligrams? Does it come in 12.5? So breakthrough, like we said, we've said before, is 1/6 of the total daily dose. So 2.5 milligrams in that case. So overall, what we've gone for is 15 milligrams of oxycodone, which you can give as 7.5 milligrams twice daily and 2.5 milligrams subcut PRN. Some people might have put paracetamol as well and changed it to IV because he can't take stuff orally. No harm in that if he's got a cannula in, because he's for palliation, which is trying to make him as comfortable as possible. You don't want to cannulate a person unless they really, really need it. Fentanyl's generally preserved for people who are in essentially CKD stage 5. Their GFR is less than 10. The reason for that is it's really, really strong. Also, you need to bridge a person over with alfentanil. So it's the kind of thing where you call over the palliative care team to do. Some of you might have put it into a syringe driver and it would look a bit like that. And again, some people might prefer to do it like that if they're happy with syringe drivers, but usually that would be an advice from the palliative care team. Yeah, so subcut, IV, and IM, morphine and oxycodone are the same doses. The only conversion is from PO to those. So the parenteral doses are the same. I would give the breakthrough subcut as well. So because they can't take it orally, everything can go subcutaneously. So you could do it as a syringe driver, or you could do it as subcut separated doses. It depends on local guidance and personal preferences. We also want to prescribe a laxative, but pretty much all laxatives are oral. The other option, there are some options for subcut laxatives, but they are under specialist supervision only because they are kind of hardcore laxatives. They're peripheral opioid antagonists or something. They're only for people who are on opioid analgesia and haven't responded to other laxatives. So really, your options are hope that he becomes able to tolerate laxatives again, oral laxatives soon, prescribe him a suppository, which he might not be very happy with, or ask the palliative care team what they think you should do, which if you're an F1, do it. They're really nice. Everywhere I've been, the palliative care team has been really nice. It's kind of their job. So yeah, if anybody's got any questions about the working out of that, I cannot stress enough, this is what I think the right answer would be. I've gone for oxycodone because he's in, what's it? Yeah, CKD stage 3B, I think. What did I put it? Yeah, he's almost CKD stage 4, so I wouldn't be too happy with morphine because it's all renally excreted. He is, and what was the other thing that might be contentious? Yeah, fentanyl. He's not, his kidneys aren't shot enough yet for me to consider fentanyl. Also, Jesus Christ, I'm not prescribing fentanyl as an F1. And I think antiemetics we're all fairly happy with, but going for subcut. I've rounded, no, that's a very good point. I've rounded it up to that because I don't think you'd ever find 14 milligrams of oxycodone. I imagine you might find increments of 5 milligrams, so you'd round it up to 15 because I imagine you'll find like 5 milligrams, 10 milligrams, and then you kind of have to mix those together to get the dose that you want. That's the only reason why I've rounded it up to 15. Really, the only thing you need to know is that for PRN you want immediate release because it's breakthrough, and for modified release, it's just longer lasting. So the idea is if you're giving somebody morphine, you don't want to give them one dose to cover the whole day because then at about 12 o'clock they'll be in pain again. So you give them 2 doses of modified release, which releases over a longer period of time. So then it covers them for longer. And if they're in pain acutely, give them the immediate release. That's all you really need to know about immediate versus modified. And it would be completely safe to go down to 10. Some people would be more comfortable going down to 10. Some people might prefer to control the pain better and go down to 15 and then bring it down if the patient becomes too drowsy. But it is completely safe to go for 10 milligrams. And again, it sort of comes down to preference and, as an F1, what your senior or the palliative care team will advise you to do. I lean along the side of I don't want you to be in pain, so I'll round. Some people lean across the side of I don't want you to be drowsy, so I will round down. But yeah, so that covers that. The last slide is just, I think somebody once mentioned, can someone talk about comprehensive geriatric assessments? All I think is necessary, at least from an exam perspective, is that this is something that's put together by the whole team, doctors, occupational therapists, physiotherapists, to create a bespoke plan for a patient. So all the stuff at the top is the stuff that's taken into consideration, and then you use that to make a problem list, make goals for the patient, and then make a care plan and keep on reviewing it. That's all you really need fully about it, I would say. But yeah, so that brings us to the end. I apologize for having overrun. I don't think you particularly need to know much detail. It's more of a practice thing than an exam thing. It doesn't come up in exams. It will come up when you're an F1 or an F2 and you'll be contributing to it. Pretty please fill out the feedback form. I really appreciate it. And I do look at the stuff and I do try to make changes based on it. So I'd really appreciate it. But yeah, I'm going to stick around in case anyone has any questions, because I know that some of the stuff, especially the prescribing stuff, can be kind of confusing, but I hope that was useful.